Hello, everyone. My name is Corey Thornton. I'm the senior editor here at Open Minds, and welcome to today's Circle Executive Roundtable, Implementing Value-Based Service Lines, the Mainstay Life Services Case Study. Today's roundtable features Jody Esper, CFO at Mainstay Life Services, and she is joined by Open Minds Senior Associate Dee DeWitt. Before we get started, I have a couple of housekeeping reminders. Your audio is muted for today's briefing. However, if you have any questions, we encourage you to submit them in the question box, and we will answer those at the end of the presentation. And finally, the slides and the recording for today's roundtable will be archived and available for elite members on the Open Minds website starting tomorrow. And with that, here is Jody and Dee.
Good afternoon. Thank you, everybody, for joining. Jody, welcome. Such a pleasure to have you here today.
Thank you. I'm very happy to be here today.
What we're talking about today is value-based service lines and their implementation. So let's jump right into it. Our agenda today is we'd like to talk about what we're here to learn about, where we are on the road to value as an industry, hear from Jody in terms of the Mainstay Life Services case study, implementing and preparing the organization for value-based care, and then, if time allows, having questions and a discussion. So just jumping right into it, learning objectives today. Process for aligning organizational financial incentives and value-based contracting, the decision-based making process for creating value-based service delivery lines, and strategies for effective implementation and tracking of value-based service lines. Translated, what I'd like to really hear and take away from this is how Jody and Mainstay actually made the decision to enter into value-based contracting, how their organization was prepared, or perhaps not, going into that, and what were the things that they had to prepare themselves for organizationally from an infrastructure standpoint, from a cultural standpoint, and what are some of the lessons that they've learned along the way. Jody is Chief Financial Officer of Mainstay and joined in 2017. She's tasked with implementing the infrastructure and systems needed to support Mainstay's mission, operations, financial objectives, and strategic initiatives. In 2023, she became the CEO of Entrust Services LLC, a subsidiary of Mainstay that provides comprehensive financial services that enrich lives of people with disabilities. Jody has more than 25 years of accounting experience, with 17 years in a leadership capacity with nonprofit human services organizations. She's passionate about the work as the mom of a son with an intellectual disability. She is an advocate and a strong supporter of the disability community. Jody received her Bachelor of Science in Business Administration and Accounting and a Master's of Science degree in Accounting from Robert Morris University in Moon Township, Pennsylvania. So, just to pull back for a couple minutes and talk about why are we having this discussion to begin with, it really brings to mind or calls into attention, where are we as an industry along the road to value? So to set that stage, performance versus value. Performance, the process of accomplishing an action, and performance measures that go into that. Value is almost always defined as the amount of performance received and paid for value. Was what was paid of good value. The performance measures are usually widely defined by who pays. In this case, we're talking about payers' health plans. And so with that in mind, what do payers want and value? Lower total cost of care, lower beneficiary spending, increased consumer satisfaction. When we talk about unnecessary use of ERs, what we're really talking about is unnecessary use of ERs drives the total cost of care. Lower hospitalization rates, again, lower hospitalization rates drive the cost of care. And in the increased use of preventative and wellness services, and I'd like to stop and just mention that focus on that for just a second. We have a lot of providers that are now becoming payviders. A good example of that in California is the Kaiser Permanente system, where they're actually the payer and they provide a significant amount of their own care. You see that a lot in payvider organizations, the increased focus on preventive and wellness care. The reason for that is because they know very, very well, as both the provider and the payer, that prevention and wellness services are inexpensive ways to reduce total cost of care, increase outcomes, and increase consumer satisfaction. What do health plans want and value? They want to retain members. They want better HEDIS scores, because those HEDIS scores and CMS star scores have an effect on what their remuneration is coming from CMS. They want lower unnecessary use of ERs, as we've discussed, a lower medical loss ratio, and they're looking at profitability, of course, as a bottom line. Consumers, they're interested primarily in rapid access, convenient, positive experiences, and low-cost services. And when we think about that, think about the retail phenomenon that's happening in behavioral health and mental health care with more and more retail access, particularly since COVID and the advent of telemedicine, retail medicine, walk-in stores, convenience. Those are the types of things that are drivers with regards to what consumers want. And by definition, well, by experience, then they translate that into the wants for the traditional nonprofit behavioral health providers. One of the things that we focus a lot on in value-based care are the HEDIS measures. HEDIS measures are basically a standardized performance set of measures. They're used by more than 90% of America's health plans. They have about 75 measures over 8 domains. Those 8 domains are on the right: effectiveness of care, access and availability of care, and you can read the list: health plan stability, use of services, cost of care, and so forth. Access and availability of care. You'll see in a lot of measures, if you're not already seeing them, timely access measures. And a lot of plans define timely access as, for example, referral to first service being 7 days or less. Those are the types of measures that we're referring to. I mentioned a moment ago CMS Medicare Advantage star ratings. Star ratings, depending upon the payer or the provider, they will impact your reimbursement. So star ratings are based on some of the same measures we just talked about, or the same domains, and that's outcomes, patient experience, access, and process measures. And again, I'm going through these a little quickly here. My goal today is really to set the stage for Jody, and these will be available for elite members for download. Some of the specific performance measures, I'm going to skip over this slide, but the Net Promoter Score is something that is widely used. It's the most widely used measure for measuring consumer satisfaction, but I'm going to skip over that now for timeliness sake. I think probably a driving force here is to ask ourselves, why are we really having this discussion to begin with? What is happening within the industry that means that we as primarily nonprofit organizations on this call and in the behavioral health and mental health industry specifically, and IDD and Health and Human Services, why do we care about value-based services? 19% of healthcare is reimbursed to provider organizations with some financial risk. 40% in 2022 of primary specialty provider organizations had value-based arrangements. That increased 50% to 60% in 2023, which is the latest available data we have. 60% of specialty care organizations receive payments that are value-based driven. That's significant. To dive a little deeper into that, I know there's a lot of numbers on this page, but when you look at this behavioral health column, the second from the left, 39% of behavioral health organizations receive 21 to 40% of their reimbursement of their revenue through value-based arrangements. And to a lower degree, 10%, 4%, and 3% receive even more, up to 61%. That's a driving force. but in terms of why we're having this discussion today, is this is the trend and the track that our industry is on with regards to how we are reimbursed. So we talked about performance measures. These are the top 5 on the left for specialty provider organizations. Follow-up after hospitalization. Basically what that translates to is when there's an ED visit, that's primarily the measure. When there's an ED visit, did that patient receive a follow-up visit from behavioral health within 7 days, and then again within 30 days after discharge? And then readmissions rates are usually scored on 30-day readmission rates, but some are scored on 30 and 90 days. But 30-day readmission rates, what percentage of the people that you're under contract to serve, when they're admitted to the ED or admitted to inpatient, have a readmission rate, and what is that rate? Emergency room utilization, access to care, that's timely access within 7 days of referral, for example. Patient and consumer satisfaction, that's your net promoter score and other scores similar to that. And then you can see on the right, performance metrics for primary care or FQHCs as well. Also driving things, we've noted this year, starting last year and this year, more dollars are being allocated from CMS down through the states for social determinants of care for Medicaid dollars. And at the same time, there's an emerging model of primary care and mental health care, integrated care. We talk about that quite a lot. This is the direction, again, the industry is going. I'm working with a organization right now as a client of Open Minds that is a hospital-based system that has a network of provider organizations that have been traditionally for the last 5 or 6 years in that network, either inpatient psych, outpatient behavioral health, or social services agencies that provide transportation, food bank, and that sort of thing. Just now, that network is adding integrated care in bringing in multiple primary care organizations into that network to coordinate among inpatient and outpatient behavioral health and the social services. So that is the direction that things are going. So with that, I'd like to turn it over to Jody in Mainstay Services, and just tell me when you'd like to advance the slides and I'll do that for you.
All right, thank you. So some of what I'd like to share with you are why data-driven is so important with our organization, some of our key performance indicators and our actual dashboards, the cultural shift that we've been able to make to use data, some of our actual value-based contract, and what's coming down the road in PA. So as far as the data-driven means for our organization, one of the most important things was the transparency of data. And I wanted the transparency of data to originate from the board of directors all the way to the frontline managers to make sure that everybody had the same information at the same time. Data-driven is important for improved outcomes. It means actually measuring outcomes and proving the quality. And being able to take that information, you have to have it to negotiate contracts along with the cost of your services. Strategic decisions to drive success, decisions based on actual data, so important for any organization. Being prepared for change. And lastly, it's really a competitive advantage. I think if you have your data, you understand it, and you're using it, it does give you that competitive edge over potentially competitors that don't have the data. So next. So some of our key performance indicators. First is board reporting, and I'm going to show you an actual example of a board report that we use. But if you were to log into our business intelligence system, these are at a very high level some of our key performance indicator areas that we actually have developed key performance indicators in all of these areas. So board reporting, I'm going to show you. The finance and cost accounting piece, this is really getting to the cost of services, electronic visit verification, AR aging. There's a lot packed into the finance and cost accounting. In the HR reporting, this is where we look at turnover metrics, recruitment, separation, all of the things important to our HR functions, performance reporting. This is overtime, productivity, utilization. In this area, before COVID started, we really were looking at our metrics as an organization on a monthly basis. And as COVID and the pandemic started, we switched to weekly reporting. And so we're able to actually see our most important information on a weekly basis, things such as numbers served, our bill units, revenue, productivity, all of these things are measured and managed weekly. In the program reporting, this is program specific, budget variances, incident management, licensing issues or corrections, all of that lies in our program reporting. Quality, this is looking at our health risk screening tools and some of our medical appointments, census and demographics, all of those quality related key performance indicators. What this business intelligence tool does is it really combines every data source that we have. So you're pulling into one place all of your finance, your payroll, your electronic health record, your state systems, every single thing that we have data, we've pulled to one place so that we can show key performance indicators and can really see at a high level how our organization is performing, and we're able to make those changes faster and able to make decisions about what contracting opportunities make sense. So next. So this slide right here, this is Mainstay's actual key performance indicators that I've shared every board meeting for 5 years now. And what this slide is and what you're seeing is the reporting that we show at the highest levels that give you a high level overview of the performance of the organization. Very important, the operating margin, there are goals set for our targets. The net assets, you can see it climbing. That would be important for the board of directors to see. Utilization, individuals served. Down in our residential occupancy and community-based productivity, there's a goal line. You can see the dotted lines. We have a 96% occupancy goal, and productivity, we have an 85% productivity goals. So the value in this is it's adding to, it's not just traditional financial statements, it's giving the board that really high level look so that they can very quickly assess and ask questions. This also is goals that are set for our team to hit. These are key performance indicators of our organization and the things that we strive to achieve. So very important, and this is great information, and it's something we use all the time. So next. Census and demographics. This is another one that we use to see how many people we're serving, in what programs we're serving them, areas that we're serving, gender, all of the important information. What I like about this one is in the left, you see a map, and that map is interactive. So I can drill in, I can drill out, I can see very detailed the number of people we're serving in different counties, the expansion as we grow. We're able to see what's expanding and where. And so this has been valuable to me, because I think when we started this, if you would have asked me, I probably would have said we're in Allegheny County, and that's just not true. Our growth and our opportunities are in all of Western Pennsylvania, and as we continue to grow, this is a great tool to see that and to be able to drill down into where the expansion and what services. Next. This is another summary dashboard I just thought important to share. And what this is this is our health risk screening tool. And what you're seeing there are our healthcare levels, our risk factor trend line, and the risk factor details. And this is an important dashboard for our medical, clinical, and program teams so that they can see those changes and they could mitigate and and minimize some of the risk factors. And so this one, behind this one, I'm showing you the summary just so you can get a taste of what we're doing, but behind this is a lot of information, and they're able to drill down into the individual details and see a lot of that information so that they can better assess some of the needs of the individuals. In that next screen, this is one of our basic HR reports. This is a recruitment and separation report, which just gives you a running head count, the number of new hires, voluntary, involuntary separations. What's nice about all of these reports is that they're interactive. So if you wanted to see more detail for a specific month, you could click on it. You can't break anything in the business intelligence system. All the data is imported from the background. So I always tell everybody, please play with it, look at your data, because you cannot break it. And you can see a lot when you drill down, and you can get into different areas and different information. You can filter down by department and different managers, and anything you want to see, it's all in here once you bring in all your data sources. This is the most important piece, in my opinion. All of those screens and all of that data and the business intelligence, it looks nice, it's great, but if you don't use it, there's absolutely no value in it. So for us, the hardest part of this and the most important part was creating a data-driven culture. It was changing the culture and how we do things. So one of the first things that we needed to do was you had to have that leadership commitment. And part of our leadership commitment was to have a series of quarterly operations reviews. And what we do for those quarterly operations reviews are we bring in our entire C-suite and all of our department leaders. We bring in finance, HR, clinical, we've got behavioral supports, we've got quality, and then we bring in each program leader. And the expectation is that those program leaders bring their business intelligence, all of their data to the meeting that they've assessed and they've analyzed, and we have a discussion about that. And so those discussions, sometimes we celebrate and we're really excited about the success we've had, and sometimes there are challenges. And so we work through where we have challenges as a team. And when you have everybody at the table with the same information and all the important people to make those decisions, to incorporate those changes, it gets the change done very quickly. And so we've seen a lot of results from this. And this was a slow process. We're in the third year of the quarterly operations reviews. And I can tell you, when we started back on the very first set of reviews, what we had to do was we actually printed off the business intelligence screens and very detailed explained exactly what the expectations and what to read and what to review. And we did that for quite a while to make sure that everybody understood exactly how to use the information and what the expectations were. So that was a really nice sort of gentle way to lead into what we really needed was this system of accountability, which is where we're at today, that we're using the data and that we're accountable for the data. The other thing that we did was to recognize and reward data-driven behavior. So we created 3 years ago an executive incentive plan. And what that executive incentive plan is it is a plan that offers bonus opportunities for meeting targets or for exceeding target goals. Those goals are based on data. They're based on our key performance indicators. And so they're measurable. And so they're able to be compensated for. We did this with a compensation consultant. It was done very planful. There is a compensation plan well documented and written that everybody signs off and agrees to. And that plan is then used for the compensation at the end of the year based on the performance. We took that plan this year and we broke it into 2 different plans. We've now added a management incentive plan, and we've taken that plan down to the lowest levels of management within our organization. And we created 2 plans because the highest level leaders of the organization and your frontline managers, they have very different goals. and very different opportunities to impact the organization. And so splitting that plan into a management incentive plan and an executive incentive plan made sense. And so we're working through that now in year 3. But what we found is that this has been received very well because the information is there and available in the business intelligence system. Everybody agrees and understands what their goals are. They're able to regularly review their goals to make sure they're on target. If they're off target, we can have discussions about what we need to do to get on target. But it's transparent. There's no secrets. It's very open, it's very honest, and it's very forthright. And so we've had success with the plan. We continue to get better at it. This is our 3rd year, so every year we learn something and we continue to improve it. And I think it will continue to have success for us. The last piece that we've done, the training and education, is so important. We developed a leadership training series. And what that is an 8-week course, and participants do 4 hours a week for those 8 weeks. Those that are in the leadership training series are newly promoted managers or supervisors within our organization, or newly hired supervisors or managers. Anybody that has supervision of someone else goes into this leadership training series. And the first step in week 1 is they go through DISC profiles and they work through understanding differences in working with their coworkers. The second phase of it is really an HR piece, and it's a very basic training to help new supervisors understand how to lead people, how to manage people, and it's the HR basics of supervision. There's a compliance piece, and then there's a large finance data piece that I do that gives you the why. So I start back at the very beginning, and because we're an ID provider, I start with the history, and I go through historically how the evolution of ID services has happened, where we are today, and where I think we're headed. And it helps sort of define for them, along with that history, is how the funding has moved and coincided. So I think that's very important, the why. And then I get into the actual way that we use data and the importance of data in helping where we're at today and where we're going for the future. And so they get really excited and engaged in a part of the data. They end up getting a finance piece with that data. They don't even realize they've gotten all that budget variance and they've learned all about budgets. It's more exciting to train them through the data process, that they've picked up all these other really important things. So the feedback that I've heard when they've left this leadership training series is, I've never heard it explained that way. That makes perfect sense to me. And there's some buy-in. And so when we do that from the very first day 1 and we get people excited and we get them on board, that helps us continue to drive and change our organization towards that data-driven culture, because that's ultimately what we want to do.
Jody, I'm just curious. I'm going to go ahead and ask a question now. Could you kind of walk us through what was it like working with your board? Traditional nonprofit boards, they may hesitate about executive compensation and performance bonuses and that sort of thing. What was it like working with them to make that happen?
That's why we hired a compensation consultant, was to help us have those discussions, because there was a mixed reaction. We had some older board members that felt that it was totally inappropriate for a nonprofit, that if there was a surplus, because that's step 1 in this, there has to be a surplus to add any incentives. But if there was a surplus, the idea was that it belongs at the frontline staff, the DSPs, or it belongs back in the organization, that it does not belong in an executive compensation. So there was some of that. Then there was a whole nother piece of our board that had worked in healthcare or had worked in for-profit all of their careers, who felt that it was very realistic that if you wanted to hire quality executive leaders and retain those executive leaders, that you should treat them exactly as they would be treated in a for-profit or in another industry. So there was a real divide in our organization and a lot of varying opinions. And I have to say, we still have our compensation consultant meet with the board because there is still some hesitation and resistance because they're just not sure that this is appropriate. And I think the idea that not many nonprofits do this yet is the other factor, is who else is doing this, and show us and tell us why you think this is important. So it has been met with some resistance and some that celebrate it. But I think what we're seeing, and we've got 3 years of information to prove, is that we have been very successful. And I really think Mainstay financially would not be in the place that we are if we weren't doing these things, because they truly change our organization. So I think the buy-in is getting there, and we'll see. We have some meetings coming up, and I'm hopeful that I've changed all of the opinions that I needed to, and that we're all in agreement.
Great, thank you. Oops.
So this is one of our value-based contracts, and this is an enhanced care management program, and it's a partnership between us, the ID provider, and the health plan. And the purpose is to improve healthcare outcomes for members with IDA. Some of the challenges as an ID provider is we don't have claims data. So lack of information about the health data. It's very hard, frontline DSPs, managers, being able to navigate these complex healthcare systems. They just don't have that skill set. Scheduling appointments, durable medical equipment was always a barrier to bringing somebody, say, home from the hospital or from a nursing home, because it's very hard sometimes for us to get the health plan to pay for the equipment that someone needs. A lot of times as an ID provider, we paid for it. So these were some barriers and challenges. And then the coordination just doesn't exist for the most part between an ID provider, behavioral and physical health. So putting that whole person care together was something that, we're really interested in doing. From the health plan's perspective, what we learned was that they had a really hard time identifying members with IDA because they only had claims information. And even if they identified those members, they couldn't reach them, and it was challenging for them. So they needed the help of the ID provider. And then the HEDIS gaps and all of their government regulatory assessments, they needed help improving those scores. And so we started this pilot program 2 years ago in order to improve all of these things for both us and the health plan. Next. So what are we doing? The first thing we had to do was identify who we supported from the ID side and who had the health plan. And so once we identified the individuals that had the health plan and were in our services, we got signed consents and agreement for them to participate in this program. And initially, this program was a quarterly interdisciplinary team that got together and looked at all of the care for the individuals that were in the plan. And then as needs arise in between those quarterly meetings, there's the ability for our nursing and medical team to reach out to their care coordinators and for us to work together to get the things that people need to make sure we can keep them out of the ER, we can get them home faster, all of these things. So some of the program expectations were reduction in HEDIS gaps in care, reductions in unplanned care utilizations and costs, reductions in readmission rates, and then an increase in utilization of benefits and preventative care. So those were some of the program expectations when we started. Next. So some of the outcomes that we found is a 50% reduction in 7-day and 30-day readmissions and a 35% improvement in closure of gap scores. So what we're able to see with these outcomes is that our collaboration and working together, it is impacting these HEDIS gaps. In addition, as an ID provider, we know that it's much better care for those individuals that are a part of this program. And this care is able to translate into individuals are home and able to stay home. So we're getting them out of the nursing homes, the hospitals, we're getting them home. And as an ID provider, we don't get paid unless they're home in our services. So it also improves the occupancy for us as a residential provider. So there's a lot of benefits in addition to the health outcomes that we're seeing. There's also benefits for the physical health plan, and there's benefits for us as the ID provider. So we've seen benefits. And how this works is there's a per member per month fee that the health plan pays us, the ID provider. And then there are other payments, supplemental value payments for meeting some of these outcomes. And so we just completed year 2, and we're working on negotiating a new contract for the start of a new year. And we've seen success, and the health plan wants to continue. We want to continue. And so we're looking at expanding those goals and expanding that contract to include other things to continue this work, because we do see success. And I also think as an ID provider, this is an example of us getting a competitive advantage, because for us in Western Pennsylvania, working with this one health plan, we know that this doesn't cover all of the individuals that are in our care. They're only the individuals that are on this one health plan. So there's nothing stopping us from going to the other health plans with this data and information and reaching out for them to also do the same program with us, so that the other members that are in our services could also benefit from this program. I think it's a really realistic goal for us to take those next steps, and I think it would be really great for those that we support to expand this opportunity.
I'm kind of curious, thinking about outcomes with this. One of the things that sticks in my mind is that ED utilization, for example, is not just an issue of ED utilization of the individual that's under the plan, but it's also ED utilization of the caregivers, because they're in a much more stressful environment. They don't get a break. And so you see across the country a lot of some attention given to that metric. Is that ever been in the conversations with this plan at all?
It has not, but I actually I would love to raise that one, because I think that's an excellent opportunity, because we know that exists. We see it every day in the stress of our staff. And I think that would be amazing to be able to incorporate them into a care management program.
I'm also curious, do you have conversations? This is usually done on the integrated care model where there's physical care and behavioral health. But I'm just interested in knowing whether or not you've had any conversations with the health plan with regard to identifying total cost and then actually sharing in the savings, as opposed to hitting performance metrics. Or to augment the performance metrics.
Yeah, so that's some of what we want to get into with this next round. We did this as a pilot just to see if there was any value in this for them and for us. And now that we've established that there is value in this, it's taking that to the next level. So we're thinking about those things now, and when we all come to the table to renegotiate what the future looks like, these are the things that we want to talk about.
Very cool. Oh, sorry.
And this, I just wanted to mention, we're an organization that's based in Pennsylvania. If you haven't heard, performance-based contracting, which is value-based contracting, is the biggest change to happen in Pennsylvania in ID services. And so what's happening is that the residential providers are being grouped into tiers, and standards are being set that residential providers have to achieve. And I just want to bring attention to one of them on the far right at the very bottom that's tossed in there, is use data to improve quality of services. So they're starting, this is the state telling all ID providers, you've got to use data to improve quality of services. So I think that just shows you how important this use of data is and is going to continue to be. This isn't something that's going away. This is something that I think we really have to focus our time and attention on. I've always said for many years, budgets are super important. I don't deny that, but budgets are based on historical information. They're great guide rails for an organization, but if you're not managing with data and you're not moving and getting ready to use this and move into these different ways of managing an organization, you're going to have a hard time staying relevant and staying contracted with some of the payers, because this is the expectation. So we have to move our organizations towards managing with data and being able to show our data for quality.
Jody, one of the bullets here talks about use of technology to support safety and independence, and then the next one, promote independence, competitive employment, etc. I'm curious as to how you're viewing the use of technology as it relates to your value-based contract, because there's been a lot of discussion this year particularly about it, and I know that it's going to be discussed again in Philadelphia next month in Open Minds technology conference there. But it's the whole idea of the use of technology to enable fewer staff to monitor, for example, supportive housing, to enable more independent living and more choice. But I'm thinking that also can be a driver, technology, into your cost structure and what you invest, based on the fact that you can actually plan on outcomes that are going to drive more performance payments. Do you have some thoughts on that?
I do. We're actually doing this. We have several homes that are supported with technology that we have. We no longer have overnight staff because we completely monitor those homes using remote technology. We're going live November 1st. We're bringing the remote monitoring in-house. So right now we pay someone else to do the remote monitoring. We go live November 1st, and we're also expanding that to 3 more homes. So we will have 5 of our ID residential homes supported using technology. So we have made a huge effort towards this initiative. We believe strongly in it because we do not see the need for 24/7 staffing in a lot of scenarios. So it's very planfully done. It's done on a series of assessments. It's implementing the technology. We've had to retrain some of our staff to be remote technicians that are serving individuals in a different way. What we're also charting, measuring, is the cost savings. So the overnight staff that you've now removed, because you don't need those staff with remote monitoring, reassessing and using those dollars for other areas of the organization and reassigning some of those staff. And it's just, there's so many benefits, and we're still working through this. We're in the midst of this, and we are very much planning and documenting and training and doing everything possible to move this initiative forward because we truly believe in it. I know I've been a strong supporter of technology, supporting people with intellectual disabilities for many, many years as a mom because I use it in my own home. And so I know the benefits, and I think the next wave coming into our services have that expectation that they're already using technology and they expect providers to use technology. So I think it's important that you have to figure out how to support people with that technology. So there's a lot packed into these changes coming to Pennsylvania.
I'm curious, what is the staff reaction to the technology? I'm imagining that it may be mixed. On the front end, I'm imagining part of it may be, oh, this is something else that I have to learn. But then once it's implemented, I'm kind of hopeful that you're going to say that there's greater staff satisfaction.
It's definitely, it's difficult. So the system of care and ID has trained the staff and has told everyone that you need to protect people with intellectual disabilities, that you need to shelter. And so our staff, and especially our long-term staff, someone that's been with our organization for 40 years, for 40 years, they have been a protector. They have been in this role of managing every aspect of someone's life every single day. So for us to talk them into backing down some of those supports, they're not convinced. And so we have to slowly bring them into seeing it this way. And some have come around. We have some that have very much said, okay, I see the value in this because this person did not need that level of support. We've also had to ask them very specifically. I can think of some of our long-term staff. We have people that love to cook or love to clean. So what we've done and how this works is you focus on what their strongest skills are. And so you need to get them excited about, well, what if your job was just cooking for, say, 3 houses? Instead of focused on this one person or one home, let's expand that role into something that you love. So you have to really think hard about the cultural change and how to manage the people side of it, because they can derail this. So those, you have to remember, those staff have the most contact with the families. So if they're unhappy and they don't agree with this change, they're gonna reach those families who might also then get scared of the change. So it's so important when you're managing this to manage all aspects of the cultural piece.
So taking that another step further, away from the technology realm, but staying in the culture realm of the staff. I'm curious as to, how staff embrace the shift to value-based care and the focus on outcomes, data-driven, and so forth. Particularly people that, as you mentioned, are used to managing every aspect and being the protector, and now all of a sudden they're metric-driven. What was that like?
I think we're still trying to get that understanding out there. It's a very hard change, and this is the biggest change to happen. And so they don't understand it. If it's working, why change it? And so that's a very hard fact. What I try to do is hit them with the numbers. If you just look at the waiting lists and you look at financially what the system of care costs, and you can see clearly that's not sustainable. So I try and talk them through all of these very basic things. And then I also try and one of the things that I'll tell them is, look at healthcare. Remember all those community-based hospitals that used to exist? They don't exist anymore. So if we want to continue to provide this really great service that we're providing, then we have to continue to change and evolve to be relevant and be a player in this new field, because it's changing.
Yeah, absolutely. Thank you. Do you want to go forward?
Sure. So this last slide, I just wanted to share, there are 71 measures in performance-based contracting in Pennsylvania. And so you can see the high level of measures in each of these needs, in each of these areas. And so we're working right now to figure out how we're going to track every single one of the measures and to get them in our business intelligence. A lot of them we have are very fortunate to be ahead on most of this, but we still have a lot of work to do. So this is how big the change is. And that's what I just wanted to stress here. I would also say the other thing that's happening in Pennsylvania is incentive payments. And so I would also say to pay attention to those incentive payments, because likely what is an incentive today could become something that's a requirement, or providers can actually be penalized for not meeting. So I think it's so important, as that's happening now in Pennsylvania, that we prepare for those things. Even if you're not able to meet those incentives, and this is any payer that offers an incentive, you have to really pay attention and get yourself geared up towards those incentive goals.
When you talk about the difficulties in gearing up for addressing all of these measures, thinking back to your earlier slides about data, and you mentioned pooling all the data into one reporting system. What were the challenges in doing that? Could you walk us through that?
Yeah, some of the challenges that we found, and this is true for any organization, is once you pull your data and you start to look at it, you find, for example, your electronic health record wasn't implemented completely or doesn't have the right information in the right places. So there's a lot of rework that has to happen, and we continually assess and make those changes as we need. We also discovered, much to our surprise, we had a human resource department that we knew was heavily paper-based, but we had no idea the level of lack of information they were putting in the payroll system. We had a payroll system that was spitting out paychecks and that was it. We weren't even tracking, when we started this, voluntary and involuntary terminations. So we had a really long way to go. But I would say not to let that deter you, because it's better to pull all your data into one place and start to look at it, because it's easier to see where you have gaps. And so for us, we went back and reworked all of these different areas that we knew fell short. And in the example of human resources, we actually went back to the payroll provider, did a re-implementation. When that failed, we did an RFP and switched payroll providers and completely changed everything to get ourselves electronic and away from paper. It was a huge investment. It was a huge undertaking. These things don't happen overnight. That one took us, I think, almost 2 years. And we've been in a new payroll HRIS system for over 1 year now. And we're 100% electronic. There's no more paper. But those are the things, they're big undertakings, but you have to start somewhere. So pull that data, look at what you got, start where you are, use what you can, knowing that you're working on or fixing. The one thing about business intelligence is you're never done. This isn't a one and done. You don't just implement this thing and you just use that same information forever. You have to continually change for whatever changes need to be made. And like, performance-based contracting is a really great example. We did not have all these metrics. We didn't know we needed them. We're right now changing our business intelligence to make sure that we are capturing all the metrics that we need to. So that's part of the continual change process that you need to manage.
Great, thank you. Just a reminder to our audience, if you have any questions you'd like to ask, we've got about 8 minutes left. If you'd like to type those in, we're happy to try to answer those. One of the things, thinking about your data that you showed us examples of, Jody, one of the things that intrigued me was the screening, for example, the HCL score. And one of the things that I noticed was that over time, your HCL score is trending higher, which I assume is an indication of, well, I'll just ask a question. Is it an indication in your mind that the people that you're serving are trending towards being somewhat more acute?
Yes, absolutely. We are watching and we're well aware of, we have an older population in some areas of our residential programs, and we see they're changing. And so those are accurate, and those are things that we're very much proactively trying to mitigate the risks.
Are you having conversations with your in this instance with the value-based contract you have with the One Health Plan? Are you having conversations with them about the increasing acuity level of the population?
Yes.
In terms of remuneration?
Yeah, if they are participating, they have to be in that health plan. That's the downside.
Yeah.
If they are, then yes, they are part of regular reviews where they're looking at all of the aspects of the care for that one individual, and they're assisting us in access to additional care that we might need.
Yeah. I know that in the behavioral health realm, there's a lot of conversation happening around acuity levels and increasing acuity levels. And health plans, I'm seeing a lot of them that are contracting for value-based care. They're obviously interested in hitting their most acute, which translate into the most costly. And that seems to be their first focus, is just that. So I would imagine it would be the same in the IDD realm. I have another question. Thinking about your executive incentive plans, you've got the management plan and the executive plan for incentives. Can you talk a little bit more about what you're doing for staff, for example, clinical staff and so forth?
So the employment and the community services or the anybody that has productivity goals, because we're still primarily fee for service. So some of them, they can be compensated directly on productivity goals.
Okay.
And so that's where some of that comes into, and it's really their managers and managing that productivity goals as well, because they have to hit certain targets.
Yeah. How successful are you as an agency in hitting those targets?
We have been really successful in our community services program, which is home and community companion, all of those services. Our employment program has struggled, and it's turnover that has really struggled with that. With our behavioral supports program, we've just changed that, and we've changed the metrics. So one of the things that we weren't capturing, and it's important for performance-based contracting, is they provide support to the individuals that are in our residential care as required. We were not documenting in our electronic health record that time that they spent internally with the individuals that we support. We were looking at their productivity as far as bill time externally for things they were being paid for. So we changed that, and it's a big change for them, and we're just working now through the productivity goals and reestablishing them to capture all of what the behavioral therapists are doing, so that we can make sure that all of their time is accounted for, but that we also can respond to performance-based contracting with the required quality of care that we should be providing.
Sure. I'm curious, thinking about the ECM slides in your ECM program. One of the things that you mentioned there was the coordination with behavioral health and with primary care or physical care, and that historically that's problematic. And when I think about some of the performance metrics, the behavioral health and the primary care, in some respects, I think may be better able to impact those metrics. And I'm wondering what is your focus with regards to trying to improve the coordination, and what are some of the challenges that you're seeing?
We would love to improve the coordination. I think the biggest challenge is us as reaching the right people. So getting in front of the health plans and getting in front of behavioral health and everyone that we need to, coming together, getting the right people at the table is the biggest challenge. And how do you find these people, and how do you get us all communicating?
Yeah. Do you have any discussions at all in terms of sharing data?
We have, and we have shared some data. The health plan has shared some data with us, and we have discussed continuing some of that work.
I don't know that I have any additional questions right now, and we are just about out of time. I'm going to turn it to the audience and ask if anybody has any questions that they'd like to type in.
Yeah, D, we did have one come in. That question was, who is determining the BP activities to be measured? Why aren't there more innovative approaches to be at least set up to do a PDSA framework? I'll leave it to you to understand the acronyms on that one.
Jody, do you have any thoughts?
I'm not sure I understood the question.
Can you repeat it one more time?
The question was, who is determining the BP, I assume best practice activities to be measured? Why aren't there more innovative approaches for PDSA framework?
Well, I'm gonna take that on a broad level to start with, if that's okay, Jody. I mentioned earlier that I'm working with a group right now, a client, and we're entering into a value-based arrangement with a major health plan, and the health plan are actually providing us with the measures. Now we negotiate what the metrics actually are in terms of the scores that we're trying to achieve, but the measures themselves, reduction in ED visits in this case, 30 and 7 and 30-day follow-up after a ED or inpatient visit, and timely access, those sorts of scoring. And in another case, one of the measures is patient engagement in care management. And that's defined by, are you able to engage a client or a patient to the point where you can meet the billing criteria for care management that allows you to bill 2 out of 3 months in every quarter. Those are all given to us by the health plan. We negotiated them, but when we asked the health plan why they were focusing on those, there were two answers. Number one is they sincerely believe that those are key drivers in reducing total cost of care. The second answer, though, I think goes back to, Jody, something you mentioned earlier, and that is what we're entering into is a pilot. And the whole idea of the pilot in this instance was to generate better data so that then we can continue to refine in the next phase what those metrics are. So I think it really goes to saying nobody has all the answers. This is something that the health plans and providers alike are all working with right now to figure out the landscape in terms of what the best metrics really are to use. And by default, they're measuring what has become traditional measures, and I'll leave it at that. Jody, you have any thoughts?
No, I think you answered that.
Okay, well, we're out of time. Thank you, and to everybody joining in. Jody, thank you so much. It's a pleasure. Corey, I'm going to turn it over to you.
Sounds good. Could you advance to our last slide? Jody, also thank you very much, Dee. As always, it's been great. And I want to thank everybody who joined us today and remind everybody that the slides and the recordings for this will be made available on the Open Minds website starting tomorrow. And that we invite you to join us next week, Thursday, October 17th at 1 p.m. Eastern for new developments in digital marketing for healthcare organizations. You can register for that event, or for a full list of upcoming roundtables, you can visit our roundtables page under the Executive Education tab located at www.openminds.com. Dee, Jody, once again, I want to thank you both very much. I hope you both have a great weekend.
Thank you so much. Thank you, Jody.